The National Health Insurance Authority has suspended 3 more health facilities from providing service to National Health Insurance Scheme subscribers. The facilities Northwestern Eye Center at Mataheko Community Clinic, also at Mataheko, and Family Maternity Home at Dansoman, all in Accra, were suspended for offences ranging from illegally taking monies from subscribers for services already covered under the NHIS and operating under poor standards and or inflating claims. Salom Adonu is Communications Manager with the National Health Insurance Authority. He's here with me in the studio. Salom, you're welcome to the program.
Thank you very much, Kamini.
Let's try and define poor standards and inflation of claims. We understand, but let's define poor standards. What did you find?
Well, thank you very much, and a good morning to your listeners or your viewers as well. The NHIA, per the scheme of things, is not really supposed to be in charge of standards, quality and all, because there are other bodies which are responsible for that. Our job primarily is to pay for the services that people give to our subscribers. So our job is to provide financial risk protection against the cost of basic health care. But in doing so, we must also ensure that what we do, we get value for money. If we pay so much, we must ensure that there are some basic things our people get. So that is why we've been careful in saying that we are not closing down the facilities. Indeed, if the standards are so bad, you should be able to close down the facility, but that is not our job. So we can only disengage you from the arrangement which existed before between the NHI and the facility. So I think that must be put in context. Talking about standards, for example, we have various levels of accreditation before you join the NHIS or before a provider supplies or provides services to our members. We have to credential you or accredit you to be our member. If you accredit you, then you can submit claims to us for payment. So there are various levels of accreditation. For example, level 1, these are CHIPS compounds. A CHIP compound doesn't need a doctor. It doesn't need, any sophisticated health professional. A community health nurse or even a midwife in some cases will do. You go to another level, the health center level, you go to the clinic level, you go to the hospital level, you go to the district hospital level, etc. And each of these levels have what we look out for before you are given accreditation. So for example, if you're a clinic and it's expected that you have a doctor, so we have to look at that before we grant you accreditation, amongst other things. If you are a hospital, you must have a theater, for example, before we can accredit you as a hospital to provide service under the scheme. So if you tell us that you have a doctor, for that reason, we accredit you for a certain level, at a certain level, and we come back during our post-accreditation monitoring, and we realize that, you don't really have a doctor, or maybe you just imported a doctor for the purposes of accreditation, after which the doctor left, and only nurses or other lower level health professionals are delivering care, at that level. That purely is a breach of the standards. So that we must ensure we bring to your attention. We will ask you to correct it. If it's not corrected, we will have to take punitive actions. So one of the punitive actions is to suspend you or is to disaccredit you.
It was one of the main reasons.
I'm just giving general.
No, I'm talking about
if you read a press statement or the statement you just read, you realize that we are a bit careful in not putting out a lot of things, because these are businesses, these are people we work with. They may correct those things that the statement said, the recommendations we made. If they correct the recommendations and they correct the problems, implement the recommendations, we will take them back because they provide service to people. So we wouldn't want to go ahead, say a lot of things which will dent their reputation so badly that people will not want to go there again. That is why, the offenses are clear, and we wrote to them, outlining the number of offenses, what exactly they are. Let me give you an example. One other facility, not about one of the 3. We went there, for example, one of them, the fridge in which they store the drugs have food elements in there. We have food wachi and things in the same fridge. That purely is not quality, it's poor quality. And you don't expect the NHIS to keep paying that facility money without pronouncing on that. That really is not appropriate. In one of the facilities, for example, the doctor in his consulting room dispenses drugs. That is not a doctor's job. The doctor is not supposed to dispense drugs. This purely, a breach of standards. So when we look at this, we can't keep our mouth shut and expect these things to go on. So we have to speak up, and in speaking up, some of these punitive actions, are slapped on them.
How often do you do this?
We do this almost every time. We have a whole directorate called the Quality Assurance Directorate. We have clinical audits. We have monitoring and evaluation offices across the regions in the country. These things are done, every now and then. But what happens is we don't put a lot of these things out because of the reasons I mentioned earlier. But I think it's come to a point where people think that the NHIS is just there, just paying money, not really looking at some of these things, because these things don't come out. For example, we may suspend a facility or disaccredit a facility. People come there. Of course, you don't expect a facility to say that because I didn't meet standards, the NHIS has disaccredited me. They'll find other reasons of saying maybe NHIS doesn't pay me on time, so I've decided to opt out. We want to put out these things so that our people know that we want to protect them, that their safety and the service they get is of paramount importance to us.
So do you do this in places like Kolebu, like, the huge hospitals that also take the NHIS?
We have officers and directors and managers and the scheme people going to every facility. Once you are accredited under the NHIS, we have people going there to do a lot of things. Sometimes after the exercise, we sit down with the hospital authorities, we show them our findings, we have a discussion, what we think they can correct, they do, what we think they cannot correct, they do. For example, you have a facility, the only facility in like an 80-kilometer radius. If you disaccredit this facility, what then happens to the people there? We think about all this. So sometimes if we can help you, come up to scratch, we will do that. Using various means, we can speak to people, we can speak to the authorities, we can speak to people to help you meet standards, because the health care of the people, in our view, is very paramount, and we do everything in our power to ensure that is done. But sometimes you can't help it than to slap the sanctions on the people.
I'm happy you mentioned money, because for some people, the second batch of suspension will bring to the number 4, because sometime last week you suspended another Accra-based hospital. And then the question now is, the NHIA seems to be on a suspension streak when you're faced with a number of challenges when it comes to paying off some of your debts.
Well, I don't know what you mean by a suspension streak. We are doing our job, and if our job requires that we suspend people, we will do it. We hear suspensions in schools, we hear suspensions of various things. If a school is suspending people, it doesn't mean that the school is on a suspension spree. It simply means that the school wants to uphold standards, so the bad ones will not influence the good ones. So it's important that there is some discipline in the system. We can't run a system with so much impunity. We can't do that. Standards must be upheld. You talked about many challenges because of delays in claims. Delays in claims is just one of the issues that NHIS has. So it will not be particularly fair to say that there are so many challenges like...
But that is your biggest challenge, isn't it?
It is, but you see, you need to understand how the procedure works. Somebody may come scream at you that the NHIS owes me this much. But if you look at really when the claims were submitted, you realize that, we have... it's a process. When you submit your claim, it takes you about 30 days to submit your claims per the arrangements you have. And we take 60 days to pay you. That is 3 months. So as we speak, if we pay March, then we are very much on track per that arrangement. You understand? As I speak, we are in the process of paying March. February has been paid a long time ago. In the process of paying March. So once we pay March, of course we owe, but you can't really say that the NHIS owes you because there is an arrangement in place. If that time hasn't elapsed, you can't really talk about a delay in claims payment. People say that to win sympathy. Of course, sometimes, we delay because of operational difficulties. Sometimes we delay because monies from the finance ministry may not have reached us on time. But sometimes, I think the pressure from the media especially is always on the NHIS side. We have quality issues like we're dealing with now, but we are always on the paying side. So because of the pressure that you mount, we may end up paying for substandard care. That is what we have to be careful about. I don't think it's worth doing that because the health of the people is important. We owe, yes, and we will always owe, because the very design of the scheme is that we will have to pay claims in arrears. You have to deliver the service first. You have to prepare the claims. You have to submit the claims. The claims have to be vetted before you are paid. Certainly, that will be in arrears. So owing is not news. Really.
Does it include the Chamber of Pharmacy and the fact that they have withdrawn supplies to NHIS accredited?
Well, I should have to talk about the Chamber of Pharmacy because, we don't deal with them directly.
You have said that before.
Yeah, we don't deal with them directly. And once we don't deal with them directly, it's difficult to make specific pronouncements on them. Our service providers have arrangements with them. So if if we go ahead of our service providers and we talk about them, then it appears we are sidestepping the arrangements. But of course, what we do affects them, and what they also do affects us, though indirectly. So they talk about not paying them. You know, we pay our service providers per the arrangement I've spoken about. When we pay our service providers will then have to pay them. If they don't pay them, we don't come into the picture. If it becomes unbearable or it gets to a certain level, we will tell, and people go to the hospitals, they are not giving drugs because their suppliers don't give them drugs, then we can come in and say, no, because of so and so and so, we have these actions against you, or you have to answer why people come to the hospital and perpetually they don't get drugs. Investigations are proving that you owe the pharmacy or the drug suppliers. What is the issue? Because we have paid you. I mean, look around, check every facility in the country today or in your vicinity.
And so you're doing that check to find out why?
No, I mean, they talk about 2 months, but you know, we may not necessarily be able to change the rules. A lot of them are strategic or policy issues. NHIA is just one member in a bigger pool or in a longer chain. We have the Ghana Health Service, we have CHAG, we have the how do you call them? The private people, we have the Ministry of Health, we have the Food and Drugs Board, we have the Pharmacy Council. We have a lot of people in the chain we work with. So NHIA alone cannot just stand and say, this is what we are doing. Everybody else should follow suit. No, we don't control people. It is a collaborative arrangement. So it's a good call. When it comes up, we will talk about it, we will negotiate, and we will see the way forward. But for now, that is the position. We will keep doing what we're doing, but we will ensure that we will advocate for monies due us from the Finance Ministry to be released quite on time, so we are also able to meet our financial obligations.
Will your standards also include the fact that, you know, you pay, but then that facility does not pay its drug suppliers? What do you do to such a facility, if that is the case?
Well, if that's the case, I mean, we'll have to look at it. If that is the case, I mean, we have what we will do to the facility. I mean, pay your people. Ensure that when our people come, they are given the care that they deserve. If they don't, and our people, we realize from monitoring and all, that our people are not getting the care that they deserve, it clearly means you are not ready for us. So our people will have to be moved elsewhere, and that means that you're going to be out of business. Let me tell you this. Providers don't tell you this. A lot of the money they get is from the NHIS. If the NHIS collapses today, a number of facilities will go down. A lot of facilities have sprung up because of the NHIS. 85% of the money they get always comes from the NHIS. And if a body controls 85% of your total revenue, you have to take that body seriously.
We'll talk more on the consequence of the suspension, now that you have mentioned that the providers are mostly on NHIA money. We'll talk about it, but let's listen to the NPP. The NPP has been commenting on the National Health Insurance. The minority in Parliament has been commenting on the National Health Insurance scheme.
At the end of the day, whatever you want to extend to other places will not be same as what was happening in the Ashanti region. Thank you. Yeah. At the root of this all, as I said, one wouldn't have anything in principle against capitation. But, as the Honorable Matthew Prempe alluded to, we came to the conclusion that as a result of these issues, coverage of CHAG health services. CHAG institutions are mostly located in the rural and deprived areas where usually government healthcare facilities are not available. Such areas are also not attractive to the private health investor. Hence, by refusing to accept the NHIS card, the majority of Ghanaians are going to suffer by not having access to healthcare services. CHAG hospitals serve as district hospitals in so many districts in the country. It should be noted that CHAG has 187 hospitals and clinics spread across the length and breadth of this country. For some regions, such as the Brahafo, CHAG institutions remain the main health service providers. Hence, by suspending services to insured clients, most people in such regions are denied healthcare services. Government refusal to listen. Ladies and gentlemen, CHAG has on many occasions sought to resolve this matter with the NHIA. The meeting with the Minister of Health in February 2014 and the Finance Minister in January 2014 being cases in point. it appears that the pleas of Chak on these several occasions fell on deaf ears. Chak gave a full month's notice to both government and the general public of their intent not to accept NHIA's card. Neither the NHIA nor the sector minister ever reacted in any way to this notice or warning. Today, it is the subscribers, the hoping against hope Ghanaians, who are suffering. To all intents and purposes, the John Mahama administration has no concern for the plight or welfare of the people of Ghana. Issues and questions that we should grapple with. Did the NHIA hear of this impending action by the Chak? What actions were taken to resolve the issues? And why should Ghanaians who have paid their taxes and premium to the NHIA suffer like this? Does the current management have the competence to manage the NHIS? We should ask. Why has President John Mahama kept quiet all this while in the face of such abysmal performance by the NHIA? How many Ghanaians is the NDC government waiting to die before they take action? If President Mahama could raise $3 million US dollars, ladies and gentlemen, and ferry it in Rambo style to Brazil, why can't we do same for our health needs in the country? After all, if resources are decentralized internally, it will not flout any anti-money laundering laws. In conclusion, ladies and gentlemen, the NDC government is insensitive to the plight of Ghanaians. The effect of their commissions and omissions is the destruction of all the good social interventions that the MPP government brought to Ghanaians in the 8 years that they were in office. Cocoa mass spraying, youth employment, now christened JIDA, school feeding program, capitation grant, and now the NHIS are all collapsing. Yet, the NDC government has not been able to add even a single social intervention program to what they met in office. It is said that literally, if you cannot offer a gift to your in-law, you do not turn around and steal from that in-law. In other words, if you cannot better the situation, you also do not destroy what you meet. For how long should Ghanaians cry before the incompetent?
Right. We don't need to go far for a reaction. Salom is still here with me in the studio. So you'd have to react to some of the matters that have been raised, laying the foundation that you are not speaking for the NDC, but you're speaking for the NHIA.
All right, thank you very much, Kemi. I mean, it's interesting, a lot of the things which have been said. I mean, these are things we've heard over and over again, and these are things which have been recycled and been thrown out to gain a certain effect. But that is fine. These are issues we can talk about every time. From where I started hearing it, he started talking about capitation. Capitation really is a provider payment system that ensures that providers are paid, ahead of time. They are prepaid, so that before you even take care of the person, you have your money. And it is the best approach, proven worldwide, to help countries reach what we call the universal health coverage, where everybody in the country has equal access to healthcare. Ghana is around 30 or 40% of that. We want to reach universal health coverage. That is a bigger goal. So the view of the NHIA and government generally is that the capitation system is the way to go. Now, let me explain what the capitation really does. Under the capitation...
But have you dealt with it well?
The capitation...
I think that's their point. The fact that you haven't done too well.
No, I mean, of course, I mean, we admit that there will always be room for improvement, no matter what. Even Usain Bolt, who is the fastest man in the world, or even wants to run faster. So he sets a record nobody can break ever. So everybody has room to improve. So if NHIS has room to improve, it is no news at all. The point we're making is that is the capitation a good program? They've admitted to the fact that it is good. But their problem is, why did we start from Ashanti? But here's the thing. We must always start from somewhere. If we started from Greater Accra, people will say, why did you start from Greater Accra? If you started from Ashanti, Upper West, people will say, why did we start from Upper West? Volta, why did we start from Volta? It had to start from a point. Right from the beginning, we knew this question was going to come up. And so we have said that we had to start from a point. And capitation pays you in advance. So delays in claims payment and all these will become largely an issue, you know, which will be assigned or consigned to the archives. People talk about the fact that under the capitation or CHAC, for example, had facilities in Ashanti which were not providing care. You know, I say that CHAC facilities in Ashanti were not affected by the strike, or they should not have been affected by the strike, because you are paid in advance. If the facilities in Ashanti, you know, are on capitation, and per the definition I've given you, it's an advance payment. Let one facility in Ashanti come and tell us that we have delayed in paying them. We pay them a week to the beginning of a new month, latest a day before the new month begins. We pay them, so they have enough money to forecast. So that is done. Nobody has complained about that. So all they are saying is, why are we not extending it to other parts of the country if it's a good program? As I speak to you, there's a technical subcommittee meeting on this. The strategic plan is being done. You well know that 3 regions have been taken for the rollout. The Volta region, Upper East, Upper West, are the next 3 regions we are going. There's massive what we call facility mapping ongoing, so we know where the facilities are and we know which people to assign those facilities. A lot of work is going, a lot of sensitization and education campaigns are going on in these regions. You know, they also talked about the fact that CHAC constitutes, CHAC takes care of a lot of, yes, CHAC is one of our most trusted
And you
people.
were reactionary in CHAC
yes,
strike.
I'll deal with that. You know, CHAC has about 187 of the over 3,500 facilities we have in the country. So, I mean, though we wish CHAC will always be on our side, and they've always been, if 187 facilities out of 3,500, you know, decide to lay down their tools in respect of taking care of NHI's people, it is quite significant, but it is not the end of the world. It is a business relationship. Sometimes things go well, sometimes things don't go well, sometimes things are okay. So if once or twice things don't go well, it doesn't mean the whole system has been shut down or the whole system is a failure. It doesn't happen like that. Even as a political party, they've had their own issues. In the recent weeks, we had issues. It doesn't mean the party should be closed down. Not so, because it's a human institution. They talked about the fact that we're reactionary. CHAC listed a number of things. The delay in claims payment was just one of the many issues. One of the other issues they raised was the fact that tariffs were low, economic situation is changed, so our tariffs must move in tandem with economic realities. The medicines list should be reviewed, so the prices are also in tandem with economic realities. And we've told them that we have started a review of the medicines list, and we are going to implement a new list on 1st July. By 29th or 30th June or so, the new list was put out. Reviewing or revising the list is a laborious process which takes a lot of months to do. So it couldn't have been that because of their actions, we quickly reviewed the list. No, they talked about tariffs. Tariff review, it's ongoing. It will be concluded in September. But as a stopgap measure, we have slapped a 12.5% increase on all tariffs we give them. So what else could we do? I said earlier that there were other strategic or long-term things they talked about. For example, not making the NHIL, the levy collected, to go through a consolidated fund. It should come straight to the NHIF, so we don't have to wait for finance ministry to release that money. But that is a strategic issue. That is a long-term policy issue. It's even a legal matter, because my understanding is that every money, tax or levy collected on behalf of the people by government should be paid into the consolidated fund before the finance ministry makes the disbursements. And we cannot violate that provision. So they know so well that that provision exists.
But it would help you more if it came directly to you.
It would help us. Then, but what it means is that we must change the arrangements as they are now, so that we'll be able to do that legitimately.
They also mentioned that
we don't alone have
abysmal in performance.
In terms of what?
How can we make the NHIA better?
You know, abysmal in performance in terms of what?
In all your dealings, you have been abysmal.
I mean, that
was the description given the NHIA.
I think the description...
That's very serious. No, abysmal.
The description had a premise. But I don't know what they mean by abysmal, because for us, all our key performance indicators have been positive. Recently, you saw the instant ID card issuance and the crowd which came with it. Does this look like a body which is performing abysmally? Will all these people have been going there? Would they have been going there to get a card, to get service? That cannot be true. When the scheme started operationally in 2005, there were just less than 1 million people. Today, we have 10.1 million people on the scheme. I don't think that's a scheme performing abysmally. You should know that.
Salam, I'm afraid we would have to end it here. I know you want to react to each and everything they said, but we'll end it here.
I'm very grateful for the opportunity.
Right, Salam Adoni is Communications Manager for the National Health Insurance Authority. I'm totally grateful for your time. I'll see you again at midday or News Today. Good morning.